So today I have the pleasure of introducing Cindy Thiede. Cindy has a bachelor's degree from Bowling Green State University. She was a college advisor and currently serves as the community liaison for Vitas Healthcare. As a Vitas Healthcare hospice representative, Cindy is often the first contact or connection that people have to learn more about health and wellness, caregiving, and hospice services that are available. She's an advocate for seniors and their families in Lake and Sumter County, Florida. Cindy is the secretary of the Lady Lake Chamber of Commerce, an Alzheimer's Association volunteer, and a board member of the International Driven Women nonprofit organization. And let me tell you, Cindy is really a driven woman because I've had the pleasure of working with her at brain fair events in Sumter County. She has a passion for bringing awareness about dementia and finding ways to support families as well as the person living with dementia. On a personal note, Cindy's from my hometown of Cleveland, Ohio, and she has 4 adult sons and has been a resident of Florida for the past 6 years. So Cindy's here today to help us better understand palliative care, hospice care, and the 5 wishes. So let's get ready to take some notes and get rid of some old ideas that we may have about some of these terms. So Cindy, I'm going to turn the meeting over to you, and we thank you for being here today.
Wonderful. So like Sherry said, today we're talking about hospice care, palliative care, and a little bit more that goes into that. We've got some screens, so I'm just going to say next when it's time to advance to the next screen. Next. So palliative care. Palliative care is designed for the person that may be hospice appropriate. Sometimes it can be a stepping stone into being accepted into hospice care. And we're going to get into what hospice care and some of those other things. But basically, with palliative care, a nurse practitioner is going to come for monthly visits to give education and support, more information about what hospice is, in addition to bringing that comfort care, that palliative care to the patient and their caregivers. So palliative care brings comfort rather than trying to cure. This is a time to encourage what quality of life means to the patient and to their family. It can kind of be a good time to go over some bucket list items too. For veterans, that might be to go on an honor flight, whether it's an actual flight or the at-home or the stay-at-home kind of flight. It might be a matter of going on a cruise or a special vacation to see family, or maybe that new great-grandchild, or maybe friends that they haven't seen for a while. Next. So the meaning of hospice and hospice care, a lot of people don't understand that hospice is a service. It's not a place. So hospice is going to be provided to the patient wherever they call home. So the loved one, the caregiver, is also going to receive services that are appropriate for them as they're caring for the patient that is under hospice service. So I get this a lot. People always say to me when I'm doing health fairs or other things where I'm speaking to the public, they think that hospice means that it's a location, but it's not. Hospice is a service. Hospice care is one that comforts, respects, values and supports with dignity loved ones and their families with an advanced illness. It's going to treat the symptoms of the advanced illness for people during their last months, weeks, or days of life. So hospice service can be provided anywhere the person calls home. It's a choice, and you can actually revoke your hospice status if you decide that you want to try a new treatment for your condition. So you can go on and off hospice. Currently, we have a patient that's been on hospice for over 2 years. So, like I said, you can go on and off hospice service, and you can come on again at any time, as long as you're still meeting the eligibility criteria. So the goal of hospice is to make the most of the time that remains, and gives control over how and where you are cared for the end of life. Folks that can actually meet the eligibility criteria, when you are able to get on hospice earlier rather than towards the very end, it can really improve the quality and quantity of life. Your symptoms are managed, your pain is relieved, and your family, your caregivers are also under care as well, in terms of being supported with education. So hospice service is provided by a team of professionals specifically trained in end-of-life care, and they will manage the patient's pain and discomfort and support the entire family around the emotional, social, and spiritual aspects of death and dying. Okay, there are actually 4 levels of hospice care. The first level is routine home care, wherever the patient may be. They may be in home, they may be in an apartment, they may be in independent living or assisted living, they may be in a memory care or a long-term care type of situation. Wherever the patient calls home, that's level 1. Then level 2 is continuous home care, or more intensive comfort care. That might be when there is a change in condition. Maybe there is an elevation in pain or other symptoms where there's more oversight with the continuous care. It can be provided at home, or it can be provided in another location. Level 3 is general inpatient care, or short time in a healthcare facility. So there's times when a patient, maybe their symptoms need to be in a situation where they are more comfortable in receiving care in a hospital setting or another setting. So that would be level 3. And then level 4 is respite care for caregivers. If anyone has been a caregiver before, you know that you need to take breaks too, so that you can continue doing the wonderful work that you're doing for your loved one. So respite care is very important, and that is actually the 4th level of hospice care. Next. So when should you think about hospice care? Consider the following questions. Has your loved one gotten worse and their medical care isn't managing those symptoms well enough? Has your loved one been to the hospital, ER, or other healthcare services several times in recent history? So we recently had a gentleman who was having fall after fall after fall, and he had been in the hospital, in the ER, approximately 6 times in a matter of 2 months. So things like this, UTIs, other medical conditions that are bringing someone to the hospital, maybe having trouble breathing. If someone is going to the ER or to the hospital several times, that might be another indication. Your doctor may even mention that there appears to be no cures or the disease isn't slowing down. The patient, the loved one might say that the treatments don't make them feel well enough to be worth those side effects. Side effects can be really at times. So you need to think about those things. All right. So choosing hospice is a healthcare decision. Patients, families, healthcare providers, they all make this choice together. There are some legal guidelines to help with this decision. A loved one can make their own choice about hospice if they are mentally competent. A loved one may also have it in an advance directive where he or she has named another person to help them make that decision. That's called a healthcare proxy or a healthcare surrogate. There we go. So if and when a loved one has one of the following symptoms, this criteria might indicate it's time to start talking about hospice and determining whether they're meeting the eligibility criteria. So there may be increased care needs. There may be some weight loss. There may be swallowing difficulties. There may be increased need for health care. Some of these things are going to be with conditions such as Parkinson's or Alzheimer's or dementia, cancer, heart conditions. When you're having chronic weight loss and really increased care needs, swallowing difficulties, the falls, it's okay to start thinking about the hospice diagnosis. Next. So who makes the hospice decision and when? So an individual may drive that decision. The doctor may drive that decision. The medical surrogate, the proxy, might also be the one that can drive that decision and speak to the physician about it. Generally, a doctor is going to help make that decision with the patient or their medical surrogate. And then the hospice doctor will work with that team to make sure that they will manage the loved one's care plan once they've been assessed and prescribed. Normally, a hospice decision isn't diagnosed and prescribed by any of the above until a loved one is considered to have an advanced illness and likely deemed that their life within the last 6 months or less, should the disease run its usual course. Hospice care may be extended as long as they're meeting the hospice criteria, like our patient that has been on hospice service for over 2 years. Their disease state normally would have been 6 months or less, but they are still meeting the criteria to have hospice service. So we just are able to extend that for that patient. A DNR advance directive is talking about and being encouraged to have such. So a DNR is a do not resuscitate. It's part of an advance directive. Next. Hospice admission. So after evaluation and assessment, a hospice admission specialist will inform you and your loved one about the clinical guidelines and hospice philosophy, as well as what services may be available. So what I like to tell people, because I get a lot of referrals being out in the community, generally what happens is when I get a referral, I gather as much information as I can about the patient what's going on, who their doctor might be. I gather some basic information. And then what I do is I pass that on to our admissions team. Then the admission team actually schedules an interview where they will go to the home, wherever the patient calls home, and they will meet with the patient, their caregiver, their family, and they will go over a list of criteria. They may speak to the doctor, go over that criteria. So it will initially start with an interview that the healthcare provider that the patient normally has will also be able to give some basic information. These interviews are free. There are no charge for them. So whether a patient meets criteria now or 6 weeks from now, they can have that interview. There is no charge for it. They are looking at the clinical guidelines, which they will talk to the patient about and make sure that everything is explained as well as possible to the patient and to the caregiver. They're going to go over pain. They're going to go over comfort levels, where to get support and answers to questions about medicines, equipment. They'll go over finances, insurance. So this means that caregiver is also going to be educated on pain, on comfort levels, where to get support. One of the wonderful, wonderful benefits of Vitas Hospice is that we have 24/7 telecare. So should there be any change of condition, maybe there's an increase in pain, maybe there's some other condition that is starting to cause some concern, like sleeplessness, that caregiver or the patient even can call 24/7 and get some answers to whether to add another pain patch, or maybe one of our nurses needs to actually come out and see the patient. So that 24/7 telecare is so, so important and a wonderful benefit. So in terms of what a patient can receive when they are in hospice service, they may, depending on what their care plan is, it can include a hospital bed. This is home medical equipment. The Vitas team actually delivers and sets up this equipment for the patient. That's going to be, if needed, a hospital bed, a wheelchair or a walker, maybe an oxygen machine and the oxygen, a nebulizer, which helps deliver medication to someone who has trouble breathing. It may include a shower chair, IVs, other supplies like wipes, briefs, lotions. It can even include massage therapy. Vitas offers massage therapy, including Reiki, to our patients. So there's a lot that goes into what can be provided for a patient who is under hospice service. All right, medications and food. So a loved one in hospice service in care may continue their normal medications if desired. Normal medications will be at a personal cost. Medications provided for their hospice service are generally covered under the hospice service Medicare guidelines. So if someone is on, let's just say, blood pressure medication, that may be a cost that they will pay for themselves. Whereas pain medication that's related to their hospice criteria, that medication generally is covered under the hospice Medicare rule. So provided free of cost and relevant to and or personal need, hospice gives medicines as needed to help with those symptoms. normally beginning with the smallest amount that will bring relief and comfort. Treating pain may start with over-the-counter medicines. It might actually start with that acetaminophen or the Tylenol. Might be ibuprofen like Motrin or Advil. Pain may escalate over time, and those medicines may no longer be effective. So stronger medicines, normal for an advanced illness, may be prescribed. Morphine is one of the stronger medicines, and it is used to manage pain. It's important to know that morphine enters a person's system and leaves the person's systems pretty quickly. So the dose is an exact measurement related to that level of pain and need. So you might see that if someone is requiring more medicine for pain, that 24/7 telecare might be really important so that they can be able to advocate for their loved one, that caregiver can advocate for that loved one, and also let the team know that there may need to be a breakthrough dose of some sort of pain medication. What you feed your loved one can make a difference to his or her quality of life and their comfort. The best way to encourage a loved one to eat is to really offer those foods that they like and foods that don't cause constipation. Many times, those stronger pain medications may disrupt the normal flow of food being digested. So constipation is a side effect. So as disease increases, even chewing or swallowing might decrease. It might be harder to chew, might be harder to swallow. So the hospice team needs to know what is going on. That again is a great way for that 24/7 telecare. If someone is having trouble swallowing scrambled eggs, it's good for the team to know so they can help decide what can be offered for that patient. The hospice team, it's called an interdisciplinary team. They actually meet once a week to go over each patient. How is their pain being managed? Are there any psychosocial issues? Are there any other medical issues? They also help with the emotional and spiritual care for both the patient and the family. They're educating and they're supporting, they're giving resources, not just to the patient, but also to the family and the caregiver. The interdisciplinary team can be up to 13 people if needed. It's always going to be a hospice physician that will work with the patient's primary care doctor. They work together. They will develop a plan of care. They'll give advice on comfort care. And like I said, they'll work with the patient's personal doctor. You will have nurses, typically a registered nurse. You may also have CNAs and hospice aides. Your registered nurse is going to visit regularly to check on the patient. They're also going to check how that caregiver, the loved one, is handling things. Are they understanding what elevated care might be? Are they understanding the patches? Are they understanding what to let the team know? So that hospice nurse has a really important job. They'll visit at least once a week. And we do have on-call nurses. Generally, they'll come if needed within a 4-hour window. Again, another reason why that 24/7 telecare is so important. We have on-call nurses that can help with any kind of elevation, education, or resources and support. Social workers are going to give emotional support and help the family understand financial and community, end of life planning information, Social workers help pull everything together. The hospice aide is going to help with personal care and keeping clean, showers, things of that nature. They're not going to be there every day. They're going to come as per that patient's care plan. So it may be once a week, it may be 3 times a week. It depends on what that patient needs. We have bereavement specialists. These offer grief and loss support, helps hold memorial services and support groups. We actually offer bereavement services for up to, I believe, 13 months after someone has passed. We have chaplains that also offer spiritual and emotional support, and they help work as a partner to make sure that that they're working with that patient's own clergy if desired. And our community volunteers are just amazing. We've got pet pals, we've got volunteers that help make phone calls. We have a veteran liaison that I work closely with out in the community. So for our veterans, Jeremy, our veteran liaison, is bedside. He holds veteran meetings. His role in the community is one that I am very proud of. He is just a wonderful young man, and he was in the Army himself. So he definitely provides a lot of support for our veterans. So means of payment. Most hospice patients are not going to have any out-of-pocket expenses. They're not going to have any deductibles or co-payments. Hospice is covered under Medicare, Medicare Part A. So anyone that has Medicare, anyone over the age of 65 that has Medicare Part A, your hospice service is covered 100%. It must be related to the patient's hospice eligible diagnosis. Payment can also be by Medicaid. So generally, Medicaid hospice benefits are going to match that Medicare hospice benefit. Private insurance may also cover some of the payment if needed for hospice. Maybe someone isn't Medicare eligible, but they have private insurance. There's also TRICARE, private pay, and there's care for the uninsured. The hospice financial specialist can answer all these questions of means of payment, and they can actually help find resources to help cover those costs. TRICARE is a fully covered benefit, and generally for military personnel. So thank you so much for listening, and I wanted to also go over just a couple things that I was thinking about as we were going over our notes. The object of palliative care is actually to reduce stress and address complex needs. It's for someone who may need comfort care, but they may still be taking treatments for a cure. Whereas once you're on hospice, that need for cancer treatments or other treatments that may have those side effects are going to be eliminated. So palliative care may also have associated costs because it's not hospice. But under hospice, you are getting comfort care. You are getting palliative care. So you're relieving the stress, you're relieving some of the pain, but straight palliative care may have associated costs, but hospice service is covered under Medicare Part A. It can get a little confusing, so that's why having the team that is able to go over all those questions and all the intricacies is so important. Five Wishes is a wonderful document. It is actually 5 different wishes. I love for people to have this. It's important to understand that on the very last page, it does need to be signed and witnessed. Some states may require another level, like a notary. But here in the state of Florida, we don't need the notary. In Michigan, you may need a notary. In Ohio, you may need a notary to finalize this document. So wish number 1 is who do I want to help make these healthcare decisions for me when I am unable to make them for myself? So it should generally be someone in close vicinity to where you are. So I like to talk about the fact that I have 4 sons. 3 of them are here in the area, but 1 is up in Kentucky. So I would choose one of my sons that are here. So should I need my son to step in as my healthcare proxy, I would choose the one that is closest here, not the one that's up in Kentucky. So you generally want to talk about this with them. They need to know. You want to make sure that this document, after it's been signed and witnessed and possibly notarized, that it's in a location that can be easily accessed. Some medical groups, your physician, they may want to put this in your records. You generally will have there's a card in the back where you can put that in your wallet. So should there be a medical situation, you've got your 5 wishes document signed, that you've got it right there in your wallet. If you need to go to the hospital, you can take it along with you. Wish number 2 is for the kind of medical treatment I want or don't want. This is really important because it kind of goes over life support treatment. What do I want? What does it mean to me? And it's pretty heavy. It's pretty heavy information. So I always like to tell people to take your time. Wish number 1 and wish number 2. Take your time, really think about it, because it can be kind of emotional. But once you get through it, you'll be so glad that you did. Wish number 3 is for how comfortable I want to be, whether I want to be in pain or I want no pain. If I show signs of nausea, shortness of breath, it's going to go over some of those little details about what you wish. Wish number 4 is how I want people to treat me. That may sound kind of like an odd request. How do I want people to treat me? But it may be things as simple as, yes, I want my pastor to come and visit me. Yes, I want friends to come. Or no, I don't. Basically, 5 wishes goes over a lot of kind of deep emotional things that really make you think about what you want and what you don't want. Wish number 5 is for what I want my loved ones to know. Maybe you may feel that you want to express that you're sorry for something that was a disagreement between a family member. So you can kind of get through some of these things little by little. 5 pages, 5 wishes. It really is a conversation. This conversation really ends up being a gift to not just to the patient, but also to their family. Because I hear so many times for folks that don't have a 5 wishes document, that and someone does have a life-limiting illness or there has been some emergency, that the family members say, if only I knew what my mom wanted. If only I knew what my brother wanted. But when they don't have a 5 wishes document, they're making decisions based on what they think their loved one might have wanted. So it's important to go over this little by little, and you will be so relieved when you do finally have it signed, witnessed, and it is in place. So you don't want to put it in a safe deposit box. In a drawer where it can be found quickly is the right place.